As described just now, my name is Dr. Gaire, and I'm currently working at Red Cross Hospital, and I'll be talking about acquired pediatric subglottic stenosis. Some disclaimers. Consent was obtained for the use of patient data. There was no intent on copyright infringement, and all the relevant data is referenced. So I'll begin with a case presentation of baby M, which a female baby who was 29 days old. Was referred from pediatric surgery with a history of stridor and intermittent respiratory distress. The patient has a background history of congenital diaphragmatic hernia with a hypoplastic left lung. You can see this in the image, which is the X-ray on the right and left-hand side of the screen. This was soon repaired after birth. The patient was intubated for 14 days, was extubated and re-intubated for 5 days further, with a history of a noisy breathing after this, according to the mother. Patient is also known to have multiple site sepsis with meningitis and hospital-acquired pneumonia, and was currently on antibiotics at the time. On examination, the child's vitals were stable with a saturation of 96%, but that was on nasal prong BiPAP ventilation with a FiO2 of 21% at 5 liters per minute. The general examination, there was no syndromic features that were seen. Had a normal oral examination, and on respiratory examination, we could witness the subcostal recessions, the good age bilaterally, but also noted that the child had biphasic stridor. The rest of the examinations were normal, and a flexible nasal endoscopy was done at that point, and was noted that the child had the true vocal cords were mobile. But they said there was subglottic narrowing which was noticed, which was graded as a Kaplan-Meier 3. This is a picture of the initial scope. It's difficult to see, but there was significant stenosis that was noted on the initial examination. So in terms of management, the child was continued on nasal BiPAP because the child was stable. We added proton pump inhibitors and adrenal nebulization, and we booked the child for a direct laryngoscopy to be done. So I'll go on to images of that. So this is our first direct laryngoscopy, and you can see in this video it demonstrates the subglottic stenosis, which we can see just below the cords. And then we proceeded then to balloon laryngoplasty. So you here this is the balloon being used to dilate the stenosis. And after dilatation, you can see that it's gone now to a Kaplan-Meier 2, and the child is much improved. All right, and then after a week, the child is having increased work of breathing again with stridor, which is noted, and the child was again taken to theater. And this is the scope before we intervene. We can now appreciate that the child has redeveloped increasing stenosis in the subglottic region and Chile. And so the child was again taken we proceeded to do laryngoplasty. And this is after the balloon laryngoplasty. You can see that it's opened up quite well. All right. So today I'll be talking about laryngeal stenosis, subglottic stenosis mainly. So laryngeal stenosis is a rare but life-threatening condition. So the subglottis is the most common area which is involved. The etiology can be divided into congenital or acquired. Congenital may be membranous or cartilaginous. Acquired stenosis most often results from accidental or iatrogenic trauma. And historically, glottic and subglottic stenosis were managed with a laryngeal reconstruction. However, more recently, management has trended towards the use of endoscopic techniques, which are less invasive and carry a low morbidity. So What are the risk factors for getting subglottic stenosis? So in terms of acquired subglottic stenosis, well, these are well-known risk factors are gastroesophageal reflux disease, intubation injury, which is the most common, and then burns, especially, and meconium aspiration, as well as the intubation of infants in general. So there's a well-described pathophysiology of how subglottic stenosis occurs from intubation. And so this diagram on the left describes that in sequential mode. So it starts with pressure necrosis, which then goes on to mucosal edema and ulceration with exposure of the cartilage, and then an infection can develop with perichondritis, and the cartilage, which leads to cartilage necrosis and granulation, tissue formation, fibration, and fibrosis, and this subsequently results in subglottic stenosis or a cyst formation. The diagram on your side of the image shows the potential sites of pressure and induced necrosis of endotracheal tube injuries. The maximal pressure exerted is on the medial aspect of the arytenoids, which is described in diagram A. And the other sites include the posterior laryngeal commissure and the circumferential subglottis, which is shown in picture B. So in terms of the differences in the anatomy of the pediatric airway, an infant larynx lies high in the neck, with the hyoid overriding the superior aspect of it. The narrowest point in the infant airway is the cricoid ring. It's the only fixed ring in the airway, and it's the most vulnerable point for iatrogenic damage from intubation. Term newborns have a diameter of the subglottis which is between 4.5 and 5 millimeters. If it's less than 4 millimeters, generally considered subglottic stenosis, and a useful guideline of the outer diameter is the 3 millimeter endotracheal tube, which has an outer diameter of 4.2 millimeters, which can be used as a quick gauge of the size. In an infant, the posterior 50% of the true vocal cords consists of the vocal process of the arytenoid as well. This is quite important. So again, just describing the differences between the pediatric and adult anatomy and the changes. And this diagram also shows the changes that can occur from the stenosis which develops. So the diagram demonstrates that small decreases in the pediatric airway have a much higher impact on the diameter and the resistance. So you can see that 2 millimeter decrease in the airway of a pediatric child results in a 16-fold increase in the resistance. So in terms of evaluating these patients, we always begin our evaluations of patients looking at the history, and we look at the reasons for the referral in general, which is there stridor, is there extubation failure, or is the child tracheostomy dependent? Then we go into meticulous history, which will include the basis for the further evaluation, which is the mode of the onset of the airway compromise, the duration, is the child stable, or is the progressive airway compromise, and is there a prior history of intubation? This is quite important. We look at the duration, the temporal relationship between the stridor, the characteristics of the endotracheal tube that is used, and the reason for the intubation. And also we'll look at associated symptoms which can be described. In terms of extubation and how was the extubation attempted before, and how many number of attempts were there, and was it abrupt failure or was there gradual failure? Again, in the examination, we look at the presence of stridor, retractions at rest, and the nature of the stridor in terms of inspiratory, expiratory, or biphasic, and the assessment of the voice quality, which is particularly important. In supraglottic stenosis, we generally see a characteristic muffled or throaty voice. In anterior glottic wave, we can get a very hoarse voice. And posterior glottic stenosis and subglottic stenosis, usually the voice can actually be normal. In terms of further investigations, we can go on to imaging. It's most useful in patients who aren't intubated or on tracheostomy dependent. Can be divided into time-related categories, which is prior to endoscopic evaluation or after endoscopic evaluation. So the most useful would be prior to endoscopic evaluation to look at the soft tissue airway films of the neck and the chest, which can be performed both lateral and AP projections. It's useful in evaluating the laryngeal stenosis. The chest X-ray can also be done, which can describe any underlying lung pathology, and a barium swallow can be done to assess the ability to swallow, the risk of aspiration, posterior laryngeal clefts, or tracheoesophageal fistula, which may be present. And then after an endoscopic evaluation, some imaging can be used. A spiral CT scan can be used, and an MRI or MRA, which can be used, but mainly to look at the intrathoracic vascular anatomy if it's needed. So in terms of further evaluation, we can go on to endoscopic airway evaluation, and the flexible nasopharyngoscope can be done, but this is only done with caution, especially in children. We must make sure that they are stable and will cope with the scoping prior to doing this. So it's performed generally prior to rigid endoscopy, and the most important information that we gather from this relates to the vocal cord movement. Normally, the normal abduction is critical information, especially prior to laryngeal reconstruction if it would be planned later. Unilateral bilateral vocal paralysis should be noted. A cricorotal joint fixation should be documented, and the posterior glottis stenosis. And of note, we should try never to advance the scope beyond the glottis because of the risk of spasm, especially in children. Okay, so this diagram just describes the sequelae of stenosis, which occurs from intubation and generally starts with alteration with an intact medium strip of mucosa, which is in diagram A, and then goes on to interrectal adhesions in diagram B, and diagram C shows that is basically showing that there is alteration with no residual mucosal strip. And then it goes on to diagram D, which shows a posterior glottic stenosis without cricoroidal joint fixation, and then eventually on to E with concentric subglottic ulceration, and into F with cicatricial subglottic stenosis. So then going on to rigid endoscopy, which is the gold standard for pediatric airway evaluation. It's prudent that preoperative dexamethasone should be given with caution and up to a maximum of 20 milligrams. We begin with an assessment of the supralaryngeal airway, looking for retrognathia, the tonsillar hypertrophy, and pharyngeal scarring. We then assess the supraglottic larynx, looking for scarring, laryngomalacia, short areoparotic folds, and arytenoid prolapse. And then looking at the glottis, we generally comment on the scarring, the anteroglottalic posterior glottic stenosis, and exclude the presence of posterior laryngeal clefts. If the vocal motion is clearly seen, we must assess the true and false chord for paralysis. And if the motion is not seen, we must do a awake nasopharyngoscopy. The subglottis should be evaluated in terms of stenosis and scarring. And if stenosis is present, we should note the position, the length, the severity, and the characteristics of the stenosis. Next, if sufficient lumen is available, we should pass the endoscope through and assess the trachea. And we should assess for suprastomal collapse if there's a tracheostomy in place and a granuloma, and for possible tracheomalacia as well as vascular compression of the airway. And the subglottis should further be evaluated for stenosis and scarring if stenosis is present. Sorry, this is already spoken about. Sorry, I hadn't gone on to the next slide, but this is what I just spoke about before. And then if the subglottic stenosis is noted, we grade it generally with the myocartin classification. And I'll go on to that now. So this is a table of the myocartin classification of subglottic stenosis, and should all be familiar with this. Generally graded from 1 to 4, and with 1 being 0 to 50%, 2 being 51 to 70, and 3 being 71 to 99, and 4 being with no detectable lumen, which is visible. In pediatrics, we try to use the modified Cosmo staging system, and this is using a Cincinnati airway CAD, which uses the size of the endotracheal tube to grade the amount of stenosis which is available, and it shows the different ages, basically looking at the different ages of the children and the different sizes of the endotracheal tubes, and and then looking at the percentage of obstruction based on the endotracheal tubes and how much pressure is it, and how much air is able to escape using a tube at 20 centimeters of water pressure. Yeah. And then a further evaluation, flexible bronchoscopy can be done in selected patients to complement a rigid bronchoscopy. It provides valuable information about airway dynamics in general, and also looks at for rings, slings, and accessory bronchus, which can be present. Gastrointestinal evaluation is good prior to airway reconstruction. It gives information about esophagitis, gastritis, as well as the status of the lower esophageal sphincter. And we also must look for gastroesophageal fistula and the cleft. And then we evaluate in terms of evaluation, we continue to evaluate for aspiration. Reconstruction has an inherent risk of converting a laryngeal stenosis child into a chronic aspirator. Therefore, a thorough preoperative evaluation will provide warning signs of chronic aspiration, such as recurrent pneumonias, as well as insidious drop in the child's baseline oxygen levels. A barium swallow can also be done, which will show the presence of aspiration as well as the type of substance that can be eaten. Then a functional endoscopic evaluation of swallowing is generally useful. The larynx is visualized while the child is swallowing, and it's valuable information on this is the relevant risk of aspiration, the mechanism of aspiration, and the presence or absence of normal laryngeal sensation. Then formal sleep evaluation can be done as well, and let's assess the child's respiratory efforts and oxygen needs. The laryngeal reconstruction is rarely warranted if a decannulation can't be achieved. So that's if children have significant lung disease, have progressive neuromuscular disorders, diaphragmatic weaknesses, and central hyperventilation syndromes. The voice evaluation is also useful. Laryngeal reconstruction frequently result in a negative impact on the voice. It's unclear which underlying pathologies or reconstructive procedures place the voice most at risk, and the extent to which the voice disorder relates to the initial etiology of the stenosis. However, it must be noted that children have a tremendous drive to communicate, which often compensates for the severe anatomical dysfunction which may be present. So then moving on to therapies, we divide our therapies into medical therapies and surgical therapies in general. Surgical therapies can be divided then into endoscopic as well as open, which can be expansion or resection, reconstructive surgery, as well as a combination, and then a tracheostomy. So medical therapy, it generally has no role if the larynx is stable and quiescent. But if the larynx is inflamed or as an active larynx has an important role in alleviating laryngeal inflammation, which improves the potential for successful operative outcomes. In children with subglottic stenosis, medical treatment occasionally obviates the need for actual laryngeal reconstruction. And in terms of medical therapy, it generally revolves around the treatment of gastroesophageal reflux and eosinophilic esophagitis if present. We should have a low threshold for the treatment with H2 antagonists and proton pump inhibitors if reflux is diagnosed or suspected. There's no in patients who have non-resolving reflux, a Nissen fundoplication should be considered, and we should refer to our colleagues in pediatric surgery. In terms of endoscopic management of subglottic skin, it's used either as a primary treatment or an adjuvant treatment before or after open airway reconstruction. It has a high likelihood of success in grade 1 and 2 stenosis with no history of endoscopic failure prior to this. Dilations are done in terms of dilation. Balloon dilation is widely adopted over the last decade, whereas boogie dilation with its associated mucosal trauma has fallen away from favor in recent years. Balloon dilation is an invaluable addition to the tools used to manage subglottic stenosis. It reduces the need for open airway surgery in up to 80% of the cases, and with a number of advantages, including its exertion of a purely radial force over the circumference of the stenosis, which minimizes the risk of airway rupture and mucosal trauma. And some of the devices are incorporated with a pressure gauge, which allows the surgeon to fine-tune the amount of force which is applied to the stenotic area. The catheters are long, narrow, and flexible, and this allows the surgeons to steer them through severe stenosis if present. Repeat dilations can be done at 1 to 3 week intervals, and up to 4 occasions is recommended. There's additional benefit from the adjuvant interventions such as steroid injection and scar division. Scar division can be performed using a sickle knife or microlaryngeal scissors or a laser. Appropriate patient selection for balloon dilatation is critical, however, and open surgery should be considered if the airway diameter hasn't significantly improved over 4 or 5 dilations. So in a study published in 2017, which was a retrospective review of the treatment of endoscopic balloon dilation and endoscopic balloon dilatation combined with an endoscopic anterior cricoid split of younger children with subglottic stenosis. And this was done in 2008 to 2015. Endoscopic balloon dilatation and endoscopic balloon dilatation with an endoscopic anterior cricoid split was performed in 3 categories of patients, which are divided into acute acquired, chronic acquired, and congenital subglottic stenosis, with a success rate of 95.5% and 66.7 and 85.7 respectively, and an overall success rate of endoscopic management at 87.5%. And there was noted to have no procedure-related complications in any of the patients, and this study basically demonstrates the effectiveness of balloon dilation. This is just one of the images from the study, and it's basically showing that they began with a first image just showing the subglottic stenosis, and then showing the division with a sickle knife, and then the effect of balloon dilatation, which is quite significant after that. So candidates for balloon dilatation, good candidates are candidates with acute onset of the stenosis, a soft and thin membranous appearance, normal airway beyond the stenosis, and no previous airway symptoms. Poor candidates are generally those with firm or mature scar tissue, multiple level stenosis, cartilaginous airway stenosis, as well as structural problems of the airway, such as missing cartilage, and patients who have longer segments of stenosis. So in South Africa, the non-occlusive balloon dilator was invented by Professor Libbe, who we all know, and is locally produced. It's safe and it's effective, and this is currently what is being used in Red Cross Hospital. So in terms of the non-occlusive balloon dilator, the benefits are that it permits ventilation during dilatation. It's useful for children and those with poor respiratory reserve. It also has all the benefits of an occlusive balloon, which were previously described in the initial slide. And of note, the results are equivalent to those of traditional occlusive dilators. So just in terms of the surgical technique that is used at Red Cross, it's generally performed under general anesthetic with the patient spontaneously breathing, and usually puts on total intravenous anesthesia. The follicular and the vocal cords are topicalized with 2% lignocaine, which reduces the risk of the laryngospasm during the scoping. The patient is gently put into suspension with a 2.7 or 4 millimeter 0-degree telescope. The right balloon size is then selected according to the theoretical age of the age-appropriate diameter of the cricoid ring and the tracheal lumen. The catheter is then gently introduced through the laryngeal lumen and through the stenosis, and the balloon is then inflated using an inflation-deflation handle, which is equipped with a syringe and a gauge and a monitor. And then the pressure is maintained by delivering to the balloon. The desired hydrostatic pressure is measured in centimeters of water, and this is reached, and we maintain it for 2 minutes in general. So during the dilatation, it's important to monitor and document the patient's vitals, such as the PO2 as well as the pulse and the blood pressure. The process is then repeated as required until the desired lumen diameter is achieved. In general, for subglottic stenosis, we do it twice, and for tracheal stenosis, it can be done 3 times. Hemostasis is achieved with adrenaline pledgets that do not obstruct the airway. And then recording of the post-dilatation airway diameter sizing is done using an uncuffed, appropriately sized endotracheal tube, and to look for a leak with a 20 centimeters of water. The patient may be intubated and admitted to intensive care post-dilatation if it's indicated. And then also in terms of post-operative, the surgeon must accompany the child to the recovery room or to the ICU. The patients who are extubated on the table and who do not have respiratory distress can be nursed in a high care ward after the surgery. Good sedation and analgesics is paramount in keeping the patients calm and avoiding excessive movement of the endotracheal tube in intubated patients as well. And which would cause more airway edema. Continuous monitoring of the oxygen saturation, heart rate, respiratory rate, and watching for signs of respiratory distress must be done for 24 hours at least. In terms of therapy post-dilatation, the therapy we generally include is intravenous and inhalational steroids, antibiotics, proton pump inhibitors, as well as adrenaline nebulizers. Follow-up direct laryngoscopy is done 5 to 7 days post-operatively, and it depends on which obviously depends on the clinical course and may include a second dilation if required. Multiple balloon dilations may be done depending on the nature of the pathology, the degree of stenosis, and the extent of the balloon dilation and the healing of the stenotic segment. In terms of complications which can occur, respiratory distress, and these are listed them. So it describes respiratory distress from mucosal edema, bleeding, granuloma formation, procedure failure which can occur, surgical emphysema, atelectasis, airway rupture, tracheitis, and tracheal lacerations. So in a study which was done in 2022, which is a prospective observational study of 20 discrete dilatation procedures which were performed on 13 patients, we were able to obtain, it was a study done to describe if they're able to maintain continuous oxygenation ventilation during the actual dilatation and of tracheal stenosis. And the primary outcome was the ability to ventilate, as I described, during the dilatation, as well as preserving oxygen saturation. The secondary outcomes included the measurement of the reducing of the stenosis and improvement in the Carter-Meyer grading. In conclusion of the study, continuous conventional ventilation could be provided during all the tracheal balloon dilatation procedures. There was significant increase in the diameter of the stenosis after the procedures, and the ability to perform, so they concluded that the ability to perform endoscopic guided dilatation through a supraglottic airway renders the procedure less invasive and improves airway control. Other options which can be considered for subglottic stenosis include a tracheostomy, which is indicated in unsafe, unstable airway, in whom laryngotracheal reconstruction is not immediately available, and also performed in the view of subsequent laryngeal reconstruction, which may be required, and a tracheostomy is generally done to do the second or to fourth rings, which we know of. In terms of laryngeal reconstruction, so I'm not talking much about tracheostomy as a laryngeal reconstruction, so just a brief talk on that. It can be a challenging, and there's no single operation that can address all types of stenosis. We evaluate every child on an individual basis, and the mainstay of laryngotracheal reconstruction is expansion cartilage grafting. An alternative approach in the subglottis is resection and reanastomosis, and stenosis involving in terms of stenosis involving the supraglottis and the anterior glottis, which is amenable to laryngoplasty. And tracheal stenosis may be managed with a slide tracheoplasty. In terms of reconstruction, endoscopy or expansion grafting can be done, and resection or slide tracheoplasties may be done. So in conclusion, the most frequent cause of acquired laryngeal stenosis remains prolonged intubation. Laryngeal stenosis continues to cause significant morbidity and mortality. The primary aim of the intervention is decannulation or preventing the need for tracheostomy. Evaluation of the pediatric airway is not considered a minor procedure. This must be noted. And rigid endoscopy remains a gold standard for patient airway evaluation. The subglottic stenosis can be managed endoscopically in selected cases with balloon dilatation, which has been proven to be an effective and safe tool. Thank you very much. These are my references.
Thank you very much. That was a really, really great overview. You're going to you mentioned that that open airway surgery can convert someone with stridor into someone with aspiration.
Yeah.
What's the mechanism of why patients better problems in terms of aspiration after surgery? Any ideas, or can Dennis comment perhaps, or Suraj? I don't know if she's on the call.
Stop shooting.
Hi, Prof. I think I obviously have an answer, but I don't know if Dennis wants to comment. I see he's on. It would be nice to hear what he says.
Shazia, thank you for throwing the ball to me. Of course, I'm on the way driving. I think after a minute, I will respond to the question as well. So you can go ahead, please.
Okay, sure. Yeah. So there are two things, Prof, that we always are concerned about is we don't want to do something that is going to cause more harm by intervening. And so a lot of kids who have glottic stenosis or posterior glottic stenosis have insensate supraglottic tissue. And if they've got scar tissue, certainly they either can't adduct the cords to the midline sufficiently, or they can't feel. And so when we do an open airway reconstruction, we actually expand the cricoid level, which means that we bring the back wall expander all the way up to the interarytenoid tissue. So if you bring that expander as high as that, you can't make it more than 5 millimeters because they will aspirate. So you've got to give them a chance to be able to swallow and close the soft tissue over that. So the mucosa in the interarytenoid area has to close in order for them to not aspirate. And so a lot of the endoscopic posterior cricoid splits with cartilage graft interpositions, because they are done endoscopically, there's a big distraction that takes place. And a lot of the centers in the US have had to go back and half the cartilage graft because kids were getting aspiration. And so it's actually very important to make sure that you've got just enough of an airway, but not to give them aspiration. So if they do have an insensate supraglottis, at least it's not enough to choke on, and there's an acceptable level of aspiration. And usually it's just liquids. So it's a case in point, which is why when we do the workup for open airway, we have to do swallowing as one of the investigations. So they get a barium swallow, modified barium swallow. They sometimes even get an esophagoscopy, and they get an assessment by a speech and language therapist. So it's really important to know that you do less harm by opening the airway. And those, I think, just to Suraj, the 5 things that he mentioned, which is really good, is you first sort out the obstruction. Number 1, sort out obstruction. Number 2, you sort out feeding. Number 3, you sort out sleep. Number 4, you sort out voice, and then you sort out exertional stridor. So those are the 5 things you do whenever you fix an airway in a child. Obstruction is first, feeding is second, sleep is third, then voice, and then exertion. So you can't make them an aspirator. It's just not right. You're giving them more problems.
Okay, so they aspirate because they can't generate a good cough, or just because they have an insensate larynx. I mean, I'm just trying to clarify.
So sometimes it's because they're insensate, Prof. And then one reason is that they're insensate. The other reason is that their posterior glottis is so scarred down that they've got a posterior glottic stenosis. So there's a thick fibrotic band on the interarytenoid muscle that is preventing abduction. And wherever the cord has sat now with the stricture, with that scar tissue, we release that scar tissue. But there's no guarantee that the cords will actually adduct to the middle again. So the cord mobility has been compromised by the scar tissue in the posterior glottis.
Okay, thank you. I think Dennis has his hand up.
Yes, thank you so much, Shazia, for taking that. And I'm sorry that I'm coming after you, which is something that you never told me to do. I think it's so nice that Gaire has highlighted all the important stuff that we should always consider when we have these kind of cases. I like managing, since my training, I like managing subglottic stenosis, especially the acquired one, very conservatively. And the fact that is what Shazia has highlighted, because the aggressive you are to the airway, the aggressive it shows it can react. And from the diagnosis all the way to the management, you really need to take every step with caution, from fiber optic nasoendoscopy all the way to the rigid scopes, and when it comes to dilatation, before reaching the ultimate goal of whatever it could be. We have seen, and Shazia, you have told me this, when you do a flexible nasoendoscopy, it is very sensitive, but it is also less specific. You shouldn't rely really on the fiber optic nasoendoscopy to call your subglottic stenosis. You can see from this case, there were 2 different pictures, from fiber optic nasoendoscopy all the way to when the direct laryngoscopy was done. So I think it was so nice that, Gaire, you have rewritten the gold standard of diagnosing these challenges, direct laryngoscopy, but there is still a role of fiber optic nasoendoscopy to see the whole dynamics of the glottic airway, because this patient, they might have even vocal cord palsy from this instrumentation trauma. And since my old times in Red Cross, we didn't do any laser intervention for the subglottic stenosis, as far as I remember. Shazia might correct me, but we saw a number of patients who had a subglottic cyst causing subglottic stenosis, and we were very conservative. But I remember we gave up for one child, not because we could not do anything at that time, but because we wanted the airway to rest. So a tracheostomy could be one of the management when you want to achieve a resting airway. Thank you so much.
Those are excellent points. Thank you, Dennis.
So I can ask another question. I mean, in adults, my impression is that patients with airway stenosis due to who be intubated due to actually overexpanded or has been there for some time. In small kids, is it the presence of a cup or is it just the presence of a tube that's causing the problem?
Yeah, so in children, we generally don't use cuffs. So the pathophysiology is different. You're quite right. Our biggest issue is poor sedation protocols. And what happens is the child is intubated. There's a very small area and a very small margin of stenosis, of edema that develops between the lining of the subglottis and the glottis and where the tube is sitting. And so in neonates, certainly with kids who are young infants who get intubated, there is a propensity to not sedate them sufficiently. And this is seen all across the world. Claudia Schweiger, you may remember her from Porto Alegre. She did an entire paper looking at the sedation of intubated neonates and infants and found that they were very poorly sedated. And because of that, they move around a lot. And this causes that ongoing tube injury at a micro level at the cords and the subglottis. And so if they improve the sedation, they will get a much sort of flatter child and less bruising of the lining. The secretions with less sedation also ends up pooling at the glottis. And so it forms almost like a biofilm. So we often find when we take patients to extubate them in theater, there's a biofilm over the supraglottis, along the cords, we see flippers. And then we see tube damage exactly where the tube has been sitting. It almost forms like we call it a keyhole. And that is one of the highest risk factors that we just have underappreciated over the years. So at Red Cross, that's exactly what happens. You'll have a child with a TAPVD repair or a TBI or a burns. All of the pathology has one common risk factor, which is the tube in the airway. Poor sedation, no Presidex because it's more expensive than clonidine. So the kid wakes up, wriggles around. There's some of them virtually self-extubate, which Jane always says is not really not really something you can describe because kids shouldn't be self-extubating, they're just light. And I think that's the issue that we're seeing, across the world with sedation protocols. So that's why, Prof. So it's not really the cuff in children, it's more the movements across from the glottis down.
Thank you. Any comments? Yeah, you the airway person here. No comments.
Thank you very much, Suraj, for the presentation. Yes. I don't see any other comments. I think we're gonna.
Dennis,
yes, Dennis, do you want to say something?
Yeah, just a comment. Of course, I don't mean to be mean, but I think it should be highlighted that fixing a subglottic stenosis should be left on the hands of people who are trained to do this, and it is not for everyone. Thanks.
Thanks a lot. We're going to end the meeting now. Thanks for attending. We'll see you on Friday for another presentation.